Just make sure that a baby who needs a septostomy with transposition needs the septostomy.
Welcome back to PedScript. I'm Zach Hodges, a pediatric ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a critical care fellow in Washington, D.C.
So Alice, who do we have with us today?
Today, we have recruited one of my favorite CICU attendings from Children's National, Dr. Greg Yurasek. Dr. Yurasek went to Columbia for med school. He did his residency at Children's Hospital of Boston, stayed there for a CARDS fellowship, went to Mass General for his PICU fellowship, and he has been a CICU attending for 7 years at Children's. We are so excited to have him for another episode.
That's right. And then today we are discussing Dr. Yurasek's favorite congenital heart disease, transposition of the great arteries.
I didn't know this was his favorite. He's a big fan.
Yeah, that's right. Such a win for us and for our listeners. We talk about those preoperative considerations, making sure we have adequate mixing of blood, talk about what they're actually doing in the OR, and then what we need to look out for that first preoperative night, but also how we should expect their course to go in the cardiac ICU.
Yes, if you know the expected course, you're just so much better with these patients. So let's get right to the content. Dr. Yurasek, thank you so much for talking with us still. Let's move on from VSD to the arterial switch operation.
So, yes, this is going to be a bigger operation. I think what we should start with is anatomy, right? Makes good sense.
Yeah. What is transposition? Is it just the tubes are flipped?
It pretty much is. We give it lots of different words and different phrases, and you know how cardiologists love their acronyms? We do a lot of those, especially of the 3 letters. We love that. Also with as many eponyms as possible. But end of the day, the fact is the aorta is coming off the right ventricle and the pulmonary artery is coming off the left ventricle. Sometimes there's a VSD. Sometimes the atrial communication's big versus small. But I think for the purposes of our discussion here, we should just take a most common type of transposition, which is called d-transposition. Fancy way of saying the left ventricle is a left ventricle and the right ventricle is a right ventricle, and their orientation with the atria are normal. And then there's ventriculo-arterial discordance, which means that the right ventricle is attached to the aorta and the left is attached to the pulmonary artery. There's no VSD. There's usually some kind of an atrial communication. And most of the time, this diagnosis can be made in utero. These days, actually, it's pretty rare for a transposition to come in with normal prenatal care that was completely missed by standard ultrasounds. It happens, but every year I do this, there are fewer and fewer patients.
I have heard of what's called congenitally corrected transposition. Is that a bit beyond our scope today?
Yeah, all you have to know about that one is the congenitally corrected is the idea that instead of atrioventricular concordance, meaning that the right atrium drains into the right ventricle and the left atrium drains into the left ventricle, in that case, there's actually atrioventricular discordance. So to take it through, there's atrioventricular discordance, there's ventriculo-arterial discordance. So the RA goes into the LV, but then the LV goes into the PA, and then the LA, right, goes into the RV, but then the RV goes into the aorta. So the systemic venous blood ends up going to the right place, and the pulmonary venous blood ends up going to the right place, but it's almost like they stopped at the wrong platform, with that platform being the ventricle. So congenitally corrected transposition, all you really would need to know is there's frequently nothing that needs to be done right away, but it does pose quite a big problem later with a lot of debate.
Oh, interesting.
So say you have that bread and butter d-TGA, they're prenatally diagnosed and the baby's born. What are those pre-op considerations that everyone is worried about?
Yeah, that's exactly what to think about. And the main thing you want to do in this situation is you always start with your anatomy, which we did, and then you think to yourself, okay, what does it mean to have d-transposition? Well, let me just take a red blood cell and just put it anywhere in the heart and I'm going to follow it around. That's the only way to do this business, right? So I'm going to just decide to put my red blood cell in the right atrium because it's sitting right there. So it should go across the tricuspid valve. It should go to the right ventricle. It's now going to go out the aortic valve into the aorta. It's going to go through the systemic vasculature and it's going to come back to the right atrium, i.e. that red blood cell did not get oxygenated. It went to the whole body, but it never went to the lungs. Similarly, let's start with a red blood cell in the left atrium. We take it across the mitral valve. That's going to be normal into the left ventricle, no problems. But now my LV is going to go out my pulmonary valve, and I'm going to go out to the lungs. I'm going to come back from the lungs. I'm going to end up back in the LA and meet myself again. I keep getting oxygen, but I'm not going out to the body. So the thing to keep in mind, the biggest issue, it's really the universal problem with the preoperative transposition, is hypoxia. It's just that simple. They almost never have any kind of dysfunction or arrhythmias or anything strange like that coming out of the gates. They're all blue, universally blue. And the size of the atrial communication and also the ductus are going to be the things that are going to determine just how blue the transposition is and if we need to do something at like hour of life 1 or not.
Interesting. So if they've got a large atrial septum and unrestricted atrial septum, they'll likely be able to establish complete mixing depending on the size of their duct. And if their atrial septum is small, if it's restrictive, then you likely will have to open it emergently after birth.
That's a really good way to put it, Alice. I think that's exactly true. And what's fascinating with preoperative transposition, and this is one of the things that I studied as a fellow, and it's like every cardiologist kind of has their favorite disease. And I'll be honest with you, this is my favorite disease. Mostly because the kids do so well with it and the surgeons are so good at treating it that it's just great to treat kids with it because they go home and they do well. The fascinating thing is that if you had a wide open atrial communication, let's just imagine that there's like no ASD, there's no atrial septum, this is wide open, right? Then you would be like, we should be fine. But if you're not getting enough blood back from the lungs and the LA is not getting enough blood, you still won't be able to get enough blood into the right atrium and then into the aorta, enough saturated blood. And so there's an interesting interplay between the pulmonary vascular resistance, which is going to be high, and the size of the ASD. End of the day, for the two things that you need for the child to kind of avoid something like you're hinting at, like a septostomy, which we could talk about in a second, you need there to be relatively low pulmonary vascular pressure. So that's why oxygen, nitric, if you need to ventilate, make the pH normal, that sort of thing, are staples with this. Prostaglandin, keeping the ductus open to encourage and foster more left atrial return. You got to start with that. If you have a good amount of blood coming back to the LA and your atrial septal defect is big enough, you'll get enough saturated blood into the RA and the baby won't need anything for the first few days of life. What's interesting is that in our institution, we do an atrial septostomy in about 60% of babies that are transpositions. I've worked at institutions that it's more like 30 or 40%, which is kind of interesting. It's very institution-based, and it's also like, how tolerant are you of cyanosis? Mm-hmm. Also, how consistent do you get the child to the operating room at, say, day of life 3 or 4? So how long will you need to tolerate cyanosis? So there's lots of things that go into play with this, but name of the game is try to keep the lungs healthy and the PVR falling, which it naturally will do. Keep the prostate on, make that LA plump, keep the hole big or make it big, and get that saturated blood into the right atrium. Should we talk about what a septostomy is and when you got to do it?
Sure, I think so.
Yeah.
I would say we all have a different threshold, but most babies, we would have them electively, if their saturation is, say, below 70 or 75% soon after birth, say within 10 minutes of being born, we would have the folks in the delivery room, the neonatal team, just intubate them there. And that does two things. The first, and you know this, the first thing it's going to do is you can then ventilate them to a normal pH. You can provide them with the oxygen they need. That's big. And if you want to use stuff like nitric, you can do that much more effectively through an endotracheal tube than through a cannula that's, halfway out of the nose. The second thing it lowers the metabolic demand, right? Because the baby's not breathing. When you lower the metabolic demand, you raise your mixed venous saturation. If you raise your mixed venous saturation, the saturation that comes back to the right atrium is higher. If the right atrium happens to be attached to the tricuspid valve, which happens to be attached to the right ventricle, which happens to be attached to the aorta, in this case, a higher mixed venous saturation means a pinker baby. And so that's why intubation and ventilation, neuromuscular blockade, sedation are typically things that we do right away. I think of like doing all the medical things first and then making sure the cath people are aware of the child's entrance. I actually will call our cath folks hours before the child's born, because I find that transposition can be pretty unpredictable. And I've had a lot of mentors along the way, but one thing that rang true many years ago, a gentleman by the name of Wayne Turetsky, who's a cardiologist in Boston, who's a great mentor of mine, always said, Greg, never trust a transposition. And I think he's absolutely right. The ones that you're like, this one's going to be fine aren't, and vice versa. Sometimes you can't trust them. So medically, you get them on Prostin. You make sure that they're sedated, that they're ventilated appropriately. You're raising their mixed venous sat. You're making sure that they're getting all the oxygen that they can. And now they're sitting looking at you, and maybe their SAT is 58, and maybe it's 85, but they're getting their first echo. And you're looking at that atrial septum. You can now feel as the intensivist that you've put the child in a winning situation. If we do the septostomy, it's because we had to. We did all the other stuff already. If you don't do the septostomy, it's because the SATs are good, and it looks like the atrial communication is big enough. And when you're taking care of these kids from the medical standpoint, you want to make sure, and one of my main goals, and I tell this to the fellows, is just make sure that a baby who needs a septostomy with transposition needs the septostomy. We never want to do any procedure in an infant, in a neonate, that doesn't need to be done. And so that's why medically it's just important to go through the things that maximize oxygen delivery and minimize oxygen consumption. Do those first, and then decide if, in fact, the hole just isn't big enough.
Sure, I have this right. For babies who have transposition, they need at least 2 levels of mixing, a PDA and then atrial communication as well. And it seems that first things we always want to do are those bread and butter cardiac ICU stuff. Increase oxygen delivery, decrease oxygen demand. And only at that point, if you do all those things and the baby's still blue, that's when you would reach for a septostomy. Is that right?
I think that's exactly right, Zach. And I'm glad you're bringing up the levels of mixing. I was just going to say something really quick on that. And there's a school of thought with transposition that if the atrial septal defect is big enough, then there should be some degree of bidirectional mixing at the atrial level, and therefore you can stop the prostin. There's a certain school of folks who feel very strongly about this. And there's an interesting study that was done about 18 months ago that looked at ABs with ample, adequate atrial communications who were on prostin, either had gotten a septostomy or it was deemed that the child didn't need to have a septostomy. And if the prostate was stopped in over 2/3 of those kids, the prostate ended up being restarted before they went to the OR. And it's exactly what you're saying. Sometimes you just need that additional pulmonary venous return in order to kind of keep that LA nice and plump. And in order to do that, sometimes you need a ductus. We know that a ductus is not a great thing. It's a runoff lesion. You can have all sorts of things from that, and neck, and the kids are breathing faster, more pulmonary blood flow, things like that. But sometimes to have the systemic saturation you do need the ductus. So I actually agree completely with what you said with the 2 levels of mixing, but make sure that you really need that atrial septal defect to be opened with a balloon if that's what has to happen.
Nice. And then it sounds like almost regardless, our goal is still to get to a repair as early as feasible for the child, like maybe within the first week of life. Would you say that?
That's right, Alice. And there's been some really good work with that. A gentleman, really, really smart guy, Michael Byrne. I actually went to med school with him. He's a cath doc up at CHOP and worked down here for a couple of years as well. Just a fantastic human being. And he did a really cool study sort of looking at, it's essentially like a Kaplan-Meier analysis, looking at like, is it actually ever advantageous to wait? And it was a big study across a lot of centers. And essentially what he was able to show is once you get to about 72 hours, there's no benefit in waiting, and there's probably some harm.
Wow.
So if you have a child that's born on a Monday, and you'll see the intensivist will be like, hey guys, are we doing this Thursday or Friday? Right? And we really believe this data, and we really like to get these kids switched quickly. And one of the big reasons, as you're alluding to, Alice, is usually these kids go to the OR with a ductus, and a ductus is not a great thing to have. Also, keep in mind you have parallel circulations with transposition. So although the effective amount of pulmonary blood flow, that is the blue blood that's making it to the lungs, is small, there's always a lot of overall pulmonary blood flow. The natural course of a transposition over the first few days of life is actually to breathe faster and faster and faster, not eat very well, need some diuretics and stuff like that. So waiting on a transposition for 7 or 10 days almost certainly is to be avoided, unless the child is incredibly small, there's infectious concerns, maybe there's some genetics things that need to be sorted out before putting the kid on bypass. That's separate for sure. But if this is a term or near-term child without any sort of sepsis risk factors who spent the first 72 hours of life just looking like a pre-op transposition, they should probably go to the OR between day 3 and 5.
Nice.
So as a cardiac intensivist, what do we need to know about the arterial switch operation? What are those common complications we need to keep an eye out for?
Yeah, so I'm glad you're asking that. The arterial switch is one of those things that I think conceptually as not being a surgeon is probably about the easiest one to, understand. You just say, well, you just got to switch vessels. And there's some really great media online to look at just the order at which that's done. And it's actually very elegant. But of course, the biggest part of the arterial switch operation is moving the coronaries. And it just kind of makes sense just to remember, because it's not totally obvious, right? You're like, well, why do you have to move the coronary? So the idea is that coming off the RV isn't just an aorta, but it's also like an aortic root, right? So the coronaries are coming off the right ventricular outflow, coming off the aorta. And so what's going to need to happen is the coronaries are going to need to be mobilized, usually with some buttons of tissue. You may recall from anatomy that, the coronaries sort of come off of the sinuses of Valsalva. There's one that's going to have a left, there's one that's going to have a right, and there's one that won't have any. And you can't take the whole sinus because the sinus, part of the sinus is the valve, right? And so you're going to need to move the coronaries with these buttons of tissue over behind, right? Because the left ventricle is in the back. And then you're going to have to patch where you took off the buttons. And so the coronary transfer is a very difficult part of the operation, and it's the most substantial, and the surgeons will tell you it's the hardest, takes the longest to learn. Then actually translocating the vessels and moving the aorta back so that it's sitting over the LV, and then slinging the pulmonary arteries forward with the MPA and moving that, which is the last part of the operation, onto the right ventricle. The surgeons will tell you that's more the macro part of the operation. So you have the coronary transfer posteriorly moving the coronaries, and then you have the great vessel switch. Just important to keep in mind that why do you move the coronaries? So you move the coronaries so that they are now beholden to systemic pressure. The early transpositions, which did very, very poorly, and this is going back to like the 70s, 60s and 70s, it was attempted a few times there. The coronaries weren't moved, and the problem was, of course, that the coronaries were still coming off the pulmonary artery. And if you think of pulmonary arterial diastolic blood pressure, it's like 10, 15 millimeters of mercury. The coronaries weren't getting enough flow. The heart wasn't getting enough oxygen and enough flow, and these patients were essentially having MIs and unfortunately essentially universally dying. But of course, it took a long time to figure this out, and you may have heard there was a period of time where we did things like mustards and sennings in the late 70s and the 80s, and we just switched the atria because there was such a fright in moving coronary arteries. And then a gentleman by the last name of Jaten, a South American, basically perfected the arterial switch operation in the late 80s and early 90s, and we've been doing arterial switch operations for transposition essentially ever since. The coronary movement is the hardest part of it.
Well, that makes sense. And sad to think about the slow loss of coronary perfusion.
It is.
Would you mind defining the Lecomte maneuver again?
Absolutely. Another great one where we use an eponym and then don't describe it. It's like perfect cardio speak, right? The Lecomte is really easy. So think of, again, it's hard to do this with just audio, but with transposition, don't think of the aorta as on the right. Think of it as in front. Because remember, the right ventricle isn't really to the right of the left ventricle. It's kind of in front of it, right? And with transposition, because there's a lack of the conal septal sort of embryologic twist that's supposed to happen in transposition, and that's actually why the mediastinum in transposition is often really, really narrow. Remember the egg on a string, right? The string is the mediastinum. It's super narrow. And the reason it's super narrow with patients with transposition is because the aorta is sitting right in front of the PAs. So now just imagine you've got this big tube in front and you've got another tube behind it and it splits in two. When you need to switch those tubes, basically what you're going to have to do is cut them both. And then before you bring the big one back, you've got to sling the ones in the back forward. And the ones that you're coming forward are going to be the pulmonary arteries because that's what starts off the LV. Hard to describe that with just audio, but that's kind of what I'm getting at. You're going to bring that forward just like a slingshot because the part where you'd put the rock is the pulmonary artery and the two slings are the LA and the RA.
Pulling it at the bifurcation? Oh my gosh. Yes, I can picture it now. I could never picture it before, but because you're like... wow.
So you just have to pull it, and what they do is literally pull it forward and then suture the aorta down over the LV. And then when they put the MPA back on top of sort of what's now the neopulmonary artery, on top of what was the aortic root, they have to have it split, right? It has to split, or there's no other way to do it. Whereas as you probably remember from anatomy, that's not really how things go, right? The MPA sort of starts anterior and to the right, and it dives to the patient's left, all of it, right? Allowing tons of room for the PAs to breathe. And they are posterior structures. You're making them anterior structures by pulling them forward, but you have no choice. And I'm glad you're asking that. That is the Lecomte maneuver. But the reason it's good to ask is that's why patients after a switch typically have some degree of branch PA stenosis. and in some degree of an elevated RV pressure. It's not that the surgery was done wrong, and the PAs themselves aren't even touched in transposition. Mm-hmm. It just means that they've been pulled and stretched, and it's something that has to be watched over time.
Gotcha. Thank you.
So say you're back in the CICU again. They're bringing you this patient from the OR. In our previous episode, you gave us a really good overview of how the structure goes for handover for these patients. Is there anything specific or unique that you listen for when you're taking over the care of a transposition patient?
That's a great question, Zach. So first of all, with all the transpositions, I always have a bit of like a pre-arrival huddle. And the reason is these kids are busy. They're not at all like the last set of patients that we talked about. And one of the main issues is that you're dealing with a neonate. And neonates deal with bypass differently and unpredictably. And when you're talking about VSD repair, like we did in the previous discussion, you're talking about kids who are 2, 3, 4, maybe 6 months old. They're more robust. These babies are usually just 3 or 4 days old. Many haven't fed very much. Their pulmonary vascular resistance is still high. It's falling, but it's still high. And they tend to have some unpredictable things that can occur as a result of a bypass surgery. In addition, bypass surgery for transition is much longer. You're usually looking, again, very surgeon specific, but typically you're looking at about 3 hours and about 2 hours of cross-clamp time. You need to obviously have the heart void of blood and still in order to move the coronaries. That takes quite a bit of time. So now you've taken these lungs, which are just developing, and the pulmonary vascular resistance, which is much higher than it would be for your 3-month-old VSD, even the canal, right? And you put this kid on a huge operation where they're on bypass for a while and the heart is stopped for a while. And suddenly you just take the clamps off and say, let's go. And hopefully everything just wakes up and is good. But you can imagine if you just think of it that way, there's a high chance that this baby is going to be a lot sicker. And it's really for the arterial switch operation really got going the idea of low cardiac output syndrome. And I think we could maybe talk about that a little bit now because that is the thing that you want to watch out with these kids. Maybe we just divide it into sort of what to worry about in the first hour or two and then what to worry about overnight, if that makes sense. So the first hour or two is very similar to what we talked about with any operation. How's the bleeding? How's the initial set of vitals? You're just going to feel different if this child arrives with a blood pressure of 80/50 versus 60/25. You're just going to feel different, right? What's the first lactate, right? For a switch, it's a long operation. Typically, the first lactate is 4, 5. That's fine. The first lactate's 15. Something is up, right? What does the chest x-ray look like? You know, not just are the tubes and everything are in place, but does it look like the lung fields are nice and open? What's the initial vent support? Is there any evidence that there's pulmonary venous desaturation? In other words, the first PO2 on a switch that comes back, you know, if the FiO2 say 40%, the PO2 should be like 150, right? If on 40% the PO2 is 80, keep that in mind. Arrhythmias and ectopy, really, really important. Not because they're going to make the child unstable. You'll have pacer wires and you can pace and do all that jazz. But whenever you see any kind of ectopy, especially ventricular ectopy, PVCs, junctional stuff, VT, God forbid, you've got to think about, is there something going on with the myocardium and myocardial health that is often associated with a problem with the translocation of the coronaries. Maybe something got kinked, maybe something is not completely right, and this patient's not getting appropriate coronary blood flow. That's typically all advertised quickly. The bleeding, the arrhythmias, sort of like the lung health, how much blood product the child needs in those first couple of hours. You got to do that stuff first. Now you enter the night. Now you're the intensivist that's on and it's, 9 or 10 o'clock at night, and all that stuff has checked out well. And we probably should spend a minute on low cardiac output syndrome, which means a little bit of a different thing to everybody. And it's got a lot of chapters and a lot of books, which tells you that we don't completely agree on it. But there's certain things that we do agree on. And it's believed to be a phenomenon after bypass. It's sort of associated with a few classic physiological problems. One is so-called capillary leak, which as a pediatric intensivist, you guys know this well. It's the idea that fluid's kind of getting out from the capillaries, from the small vessels through these gap junctions, and you're just third spacing a lot. And these babies, universally, a kid that gets a switch looks a lot sort of beefier and more edematous the next day than they do the day that they come up. And they're all going to have a lot of that third spacing. It has to do with sort of the neonatal vasculature and the long bypass and cross-clamp times. You're going to see capillary leak for sure. you're going to see this idea called diastolic dysfunction, which is a somewhat poorly understood phenomenon, but the idea that the patients tend to need more volume and the ventricles to be at higher pressures in order to sort of have adequate systole and adequate stroke volume. And that's a both sides of the heart thing, not really a left ventricular thing. And so you'll often see these kids come up, the stroke volume's not very high, or you'll hear the bedside nurse appropriately saying, it seems I need a CVP of 10 or 12 or 13 in order to have good blood pressure. Listen to that nurse. They're almost certainly right. So acute diastolic dysfunction, which could be some sort of a subendocardial ischemia phenomenon that generally goes away in a day or so. Capillary leak for sure. And then people have postulated things at the mitochondrial level that there's actually like just an inability to have adequate gas exchange, Cori cycle anomalies, and all sorts of biochemical fun that we won't get into right now. But it's a phenomenon that absolutely happens. And that's what it looks like, but it's sometimes difficult to tell, difficult to explain on the molecular level. That's exactly why it happens. What you typically will see in these kiddos a few hours after is just those things, though. Maybe requiring a little more volume. With the capillary leak, there's less intravascular volume. So let's think about what that's going to mean. The CVP might be higher, right? The heart rate might be higher, right, depending on how cool you're keeping the patient. And remember, the heart rate's going to respond to stroke volume, and the stroke volume might not be as good if the output's not as good. The child's urine output might be very poor, and universally it is poor for the first night after a transposition. And then you might have other sort of ventilation things that occur because as the lungs get boggier and boggier, because the child's not making a lot of urine, you will develop AA gradients. You will develop some degree of pulmonary venous saturation. And so those are the kinds of things that I think about when I think about low cardiac output syndrome. Another thing that people will add to this is actual arrhythmias as part of the LCOS, not related to coronaries.
Oh, interesting.
And so seeing jet, seeing even transient block, and even seeing a lot of atrial tachycardias, even with perfect coronary health, is well established. So to answer your question, I think that the things you want to look out for as you're beginning to establish that reserve going into your first night with this child is about how much fluid do I need to give this child to have the stroke volume, the blood pressure, and a lactate that's appropriate, and of course the examination, right? And we use a lot of NIRS, which Zach, you probably use in your place too, sort of near-infrared spectroscopy as a surrogate for central venous saturation or systemic venous saturation. You have to figure that out. You got to figure out, are your pacer wires working? Do I need to pace this baby? And what am I pacing them for? And then you really kind of have to get on top of, okay, what ways do I have of getting fluid out of this baby when they're not making a lot of urine? Things like peritoneal catheters and things like that can be really, really helpful to keep these children from getting too volume overloaded in those first few hours. Once you get to hour 16, 18, I often think it's more like 24, that capillary leak seems to resolve. The ventilation anomalies seem to also resolve. The urine output picks up, which goes along with that. And most of these patients do really, really well. And outside of 24 or 36 hours, recovering an arterial switch operation, if it's done well, is actually really straightforward.
Sort of get through the first day, then get the chest closed, diaphragms, get yourself extubated, that type of thing.
Exactly, Alice.
Well, thank you. We have so much respect for this procedure. This is really fantastic.
So that was a great overview on what to expect that first postoperative night. Kind of as we move forward in the hospital stay, how do you end up dealing with those common barriers to discharge? So when do you want this patient extubated? When do you want to get all the hardware out of the patient with lines and tubes? What else comes to mind?
Great question, Zach. So these patients, because they're younger, neonates, and it's a bigger operation, they're going to recover quite a bit more slowly than a VSD. I could give you sort of the ideal course for these patients. In our institution, we typically bring up switch patients open-chested, and that's to facilitate a couple things. As you might imagine, it makes the ventilation a lot easier. Sort of that diastolic dysfunction that's common, that's easier, right? Because you can continue to fill the ventricles without believing you're going to be causing significant ventricular interactions. And just the whole general profile is easier when the chest is open. If you needed to go on ECMO, the chest is open. It takes just a few minutes. There's a lot of advantages there. Getting the chest closed is usually a next day thing.
Nice.
So it's either done in the OR or usually the next day. Unlike a single ventricle palliation like a Norwood, these patients usually are closed the next day, 2 days at the most. Typically, a switch can extubate, in my experience, 24 hours after chest closure. And there's a couple of ways to facilitate that. The one is you obviously want to make sure that the child is calm, and you want to make sure that they're completely, sedated and muscle relaxed while they're chest is open. But as you're getting ready for the chest closure, think about lifting the muscle relaxant then. Think about how little sedation a neonate typically needs. If you have this baby on all this fentanyl and other adjuvant drugs and they're still muscle relaxed, and then you turn the muscle relaxant off the night after the chest is closed, that kid's going to extubate in 2 or 3 days. If you prepare for the extubation as sort of the next part of the surgery, if you will, you can usually get these babies extubated the next day. Get the chest closed. It's usually a late in the day thing, but have the sedation down, have anything else that you might think you want, like extra diuresis before the chest closure, because they usually take on a little bit of fluid as part of the closure. Have all that set, stop the sedation or go as low as you can as soon as the chest is closed, and often these babies can extubate the next day.
Wow.
The next part of the recovery is how they're doing with being extubated, and that's a bigger topic. I think briefly what I'd say is they need a few things to go well, and are all quite related to the surgical procedure and the surgical technique. The first is the diaphragms, which of course are innervated by the phrenic nerve. They can get sort of pinched when the lungs are pushed back and reinflated after the operation, and that can cause like a phrenic nerve palsy or diaphragmatic paresis. Unlike you and I, we can breathe our intercostal muscles. A 4-day-old child needs both diaphragms working perfectly, and they will fail extubation essentially universally if that is a problem. Sometimes they need a diaphragm plication, which is basically tacking the diaphragm down, or at least more time on a ventilator before moving forward. Another thing is vocal cord paresis, and that's just because, again, you're working right up when you're doing the switch area, you're really close to the recurrent laryngeal nerve, and you can have left vocal cord paresis. This can lead to like a poor cry. This could lead to risk for aspiration and stuff like that. So those are important things that you find out about when you extubate, but you can't really probe for them when the child still has a piece of plastic through their vocal cords. So you take the tube out of your transposition, and they're breathing symmetrically, and it looks like the respiratory rate is maybe 50 or 60, and that's appropriate. Chest tube drainage isn't too much, and the cry was really good. If you couple that with a good echo and a good first post-op night, you're really getting somewhere. If you don't have that, you're going to need to go do some investigation and find out what's going on with the diaphragms, with the vocal cords. Maybe to keep the kid on some vasoactive support for longer, that sort of thing. If this checks out and you're doing well, you might only be on 2 days after the operation right now, maybe 3. And the whole thing is feeding. And that's just because these babies, unlike the last chapter we did, they've never fed before. I mean, maybe they've had a little bit of milk, before they've actually, went to the operating room. But now we're going to challenge them with how much can we tube feed them, and can we get to full feeds? And then can we give them a bottle and go up on their oral feeds more? And honestly, that's what keeps, when you look at this operation, that's what keeps kids in the hospital the most amount of time. Our average amount, our median, for days in the ICU after switch is 4. A lot of kids is 3. So I kind of think like about 2 to 3 to get extubated, and another 1 to wean down from your vasoactive or respiratory support to be able to go out to the floor. But then the amount of time that's spent on the floor working on feeds and just normal baby stuff, the baby's got to wean from diuretics, establish like good feeding coordination, tolerate feeds, ends up being about 2 weeks.
That's really a great roadmap and expectation. And I'm thinking about the switches that we've been taking care of this month and thinking, okay, they met this, they didn't meet, right?
Right. Sometimes it takes quite some time. And as you know, Alice, we've had a couple in the last month, just being a little premature. I think of that baby was here probably an extra week, right? Just average lung health, what seemed to be a higher requirement for diuretics, things like that. And so each baby is a little bit different. But normally I would tell families prenatally, if you're doing counseling, that tell them you probably be in the hospital for the first few weeks. We shoot for about 2 weeks, and you'll probably be in the unit for most of the first week. And usually it's a little bit less than that.
So as we kind of begin to wrap up this topic, are there any long-term complications that we should keep in mind for these patients? Maybe if they come back to the ICU for another reason in the future?
So another really good question, Zach. And I think, so early on, we think about, the right ventricular pressure being elevated, again, because of the comp maneuver and the relative stretching. So it's a little different than stenosis. It's stretching of the PAs. And sometimes kids just deal with this great, and the PAs grow and there's no problem. And some of these kids a year later come back with systemic RV pressure and horrific tricuspid insufficiency, and they need to go for PA plasty and stuff like that, or cath or surgically based. So the health of the RV is really important. The health of the coronaries over time is really, really important. And there are substrates of kiddos who will require interventions on that later. Although honestly, it's quite rare. The, survival to 1 year for transposition patients is over 97% nationally. So you can feel really good about taking care of a transposition. But the jury's still out as far as, exercise capacity and things like that. The great majority of these babies are in kindergarten when they're 5 years old, which is what we all want as parents. But a fair amount of babies who have undergone any kind of operation as a neonate do have other neurodevelopmental things, whether they're mild motor things, ADHD, and things like that. So it is important to know with families that their risk for all these things is higher, all of them. They may not map out that way, but it's higher for all of them. Anatomically, though, other than right ventricular health and watching for things like arrhythmias, these patients do very, very well. It's incredibly uncommon for these patients to require a heart transplant or develop heart failure out of nowhere when they're 15. But I think a good thing to end on is let's just keep in mind that it's, 2022, and we perfected this operation, we think, around 1990, right? So the three of us on this call, now I got quite a few years on both of you, right? But most of the transpositions out there, pretty much none of them are older than us, right? So are they going to develop heart failure in their 40s or their 50s? Are they going to develop coronary vascular disease younger than your typical American? I have no idea. And there's no way to know because that's how new this operation really is.
Oh, interesting. We will need to continue to follow them.
Absolutely.
This has been a great conversation. I really appreciated you spending your time with us. I've definitely learned so much more about VSD in our previous episode. And then, of course, now with arterial switch. It's definitely something that I wish I had access to a year ago going into the CVICU.
Well, it's a pleasure being here.
Yes. Thank you so much. And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.